Hello, everybody. My name is Sureda. I work at the Clinical Hematology Department of the Catalan Institute of Oncology in Barcelona, Spain. And it's for me a pleasure to discuss with all of you uh, CAR T cell therapy associated toxicities and how we are managing them. So, as you know, CAR Ts have revolutionized the treatment of hematological malignancies. They are considered nowadays a curative therapy for a specific subgroup of patients, but unfortunately, they are associated to several toxicities that we have had to learn to diagnose them and to manage them properly since we started treating these patients in prospective clinical trials and, of course, outside prospective clinical trials. I would divide toxicities in those that are early toxicities after CAR T cell infusions, that probably were the ones that were worrying us clinicians significantly from the very beginning. But of course, we know that there are mid and long-term toxicities that we also need to take care of. So talking about early toxicities, the two most important ones are CRS, cytokine release syndrome, and ICANS, basically neurological toxicities. And both of them, although the physiopathology of ICANS is a little bit less well understood, are basically related to the fact that after the infusion of CAR T, there is a massive activation of these CAR T cells that produce a secondary activation of additional T lymphocytes and other cells that produce release of different cytokines. We started to manage both CRS and ICANS in prospective clinical trials, but we have been able, of course, also to manage these two complications outside prospective clinical trials. The most important drug that we are using to treat CRS nowadays is tocilizumab, and the most important one to treat ICANS are corticosteroids. I want to mention that sometimes ICANS are being developed in patients that have already CRS. Over the last few years, we have been able also to depict or to clarify some subgroups of patients that are going to have a higher incidence than in the global population of patients of CRS and ICANS, and basically the clinical characteristics that we can identify for these patients developing more frequently CRS and ICANS are basically related to tumor burden, also the age of the patient, and performance status. So outside prospective clinical trials nowadays, we have the tendency to start tocilizumab earlier than before, eventually to use pre-emptive corticosteroids, and also to start treating patients with ICANS earlier on. And because of that, when we have a look at the toxicity that is being reported outside prospective clinical trials, the incidence of grade 3 or plus CRS and ICANS is decreased from what we were able to see in the first pivotal trials. In addition to CRS and ICANS, that probably were the two side effects that were worrying us much more initially, but in reality, they don't constitute the most frequent cause of death of patients being treated with CAR T. We have to take into consideration hematological toxicity and, of course, cytopenias after CAR T. We are developing strategies to manage cytopenias after CAR T, and we have also developed a really very strong guideline regarding prophylaxis of infections, because we know that probably infections are the major cause of treatment-related mortality in these patients. So that's this is one aspect that usually does not appear at the very beginning, but that we have to take into consideration. And this has also I want to make some specific comments regarding this type of toxicity, because sometimes if patients go back to the referring centers, these delayed toxicities have to be managed basically commonly or basically by both the referring center and the center that has already treated the patient with CAR-T. And I also want to give a few or to make a few words regarding developing of secondary malignancies, which is very hot, very important and hot topic nowadays. We have several reports reporting secondary malignancies in patients being treated with CAR-T. Basically, myeloid malignancies, myelodysplastic syndromes, and also acute myeloid leukemia. We are still learning exactly which is the profile of the development of secondary malignancies in patients being treated with CAR-T. And of course, when thinking about the last treatment strategy developing or favoring the development of secondary malignancies, we also have to take into consideration that this patient has received quite a lot of chemotherapy and eventually radiotherapy before receiving CAR-T. So we need to establish which is the potential impact or the potential weight that the prior therapies or eventually the CAR-T cell therapy have in the development of secondary malignancies in these patients.